Okay, well, maybe why don't we start? It's 6:05. I think people, some people will probably drift in. So maybe I'll say a couple of comments and hand it over to Albert, and then hand it over, I guess, to the Sunnybrook team. So I think so. Welcome everybody to one of our U of T spine program events. Thank you to Nadia, our program manager, for helping to coordinate things. And this evening will be hosted by our colleagues at Sunnybrook, and I think the focus will be on spine oncology. This evening should be quite interesting, looking at some different treatment options related to spine on oncology, and I think we'll kind of look forward to that and having some good interactive discussion. So I think one of the positive effects with the COVID pandemic has been the use of these virtual technologies to kind of bring our community closer together. We've seen a number of these events, and I think this this case discussion evening that's hosted by each of the hospitals is a really great event. So thanks very much for putting this on, and maybe at this stage I'll hand it over to Albert, and then I guess we'll introduce the faculty at Sunnybrook to run the show.
Great. So thanks so much, Michael. Thanks. I assume it's Nadia. You've been our program manager has been stick handling the scenes and the views, so getting used to this new format here. So welcome everyone, and it's great to see everyone. I hope everyone's continuing to keep well and safe during these times, and we're sort of continuing on our academic calendar events as part of the citywide spine program, and this is really just an extension of our case discussion series, and pleased that Sunnybrook, under the leadership of Joel Finkelstein, our division chief, is kindly hosting and moderating this session for us this evening. We've got a variety of folks at Sunnybrook that have a lot of interest in oncology, and obviously at Sunnybrook, having one of the two sort of regional cancer centers in Toronto, the Odette Cancer Center. There's a lot of opportunities for interdisciplinary care and collaboration in both clinical research and educational efforts. So thanks so much to Arjun Sahgal, Jeremie Larouche, and team, as well as Nadia for organizing this evening. And I'll turn the virtual podium over to Joel momentarily. Just do want to acknowledge that our program does receive support from a variety of key industry partners. So Medtronic, Stryker, Zimmer, Dupuis Synthes, and obviously appreciative of their ongoing support of our program, in particular during these challenging times that we all face. So thank you, Joe.
Okay, so I'll take over the virtual podium, and welcome everybody. I'm going to just moderate this session. Let me just take over the screen here. I'm going to just begin with a short talk to try to frame what we'll be talking about, and then we'll highlight this with three cases. So let me just get this opened up here. Share. Okay, can everyone see my screen with that?
Yes. Yes.
Okay. So what I'm gonna do is I'm just gonna give a very short talk to talk about the changing paradigm in metastatic disease. And what I'm doing here is I'm gonna show a comparison of two population-based studies that we performed at Sunnybrook through ISIS. And it looks at cohorts of surgery on the spine for metastatic disease in the period of 1991 to 1998 and 2006 to 2016. So if we just take some of the key points, this is just the rate of surgery by primary cancer diagnosis. And you can see that in 1991, the cohort 20 years ago compared to now, there's a big difference there's an increase in the amount of breast cancer as that is done primarily, and a decrease in the amount of lung cancer. You can see lung cancer was like the most common primary site that was done back then, and now it's one of the least common sites. So a decrease in lung cancer, increase in breast cancer. The tale of the two times. Well, the 30-day mortality rate has improved has improved a bit, has improved a little bit. Overall, 1-year mortality has improved. The median survival of all cancer types has improved, and the readmission rate, 30-day readmission rate has also improved. The median survival by primary cancer type, you can see, has also improved for all types. And you can see the big improvement in lung cancer and the big improvement in breast cancer. So we're offering less on lung cancer, but the survival rates are higher, and breast cancer survival rates are also higher. So what are the initiatives that have enabled these changes? Like, what's changed over these past 20 years, and what have we learned from, research and from our experience? Well, there's multimodal treatment for spinal metastases. The changes have come in all areas. Advances in genetics with targeted therapies such as the EGFR mutation non-small cell lung cancer, which has created a bimodal distribution for life expectancy. So we know that certain types of lung cancer do well as opposed to others. So these are the ones that we can expect better outcomes and direct our surgery to. Bone health with denosumab to reduce skeletal complications, targeted therapy in chemotherapy for estrogen, progesterone, EGF receptor positive patients. And what we're going to really focus on is the advances in things such as classifications, algorithms such as the CINS classification, the Bilski classification, the NOMS framework, refinements in surgery, improvements such as less invasive surgery, minimally invasive surgery, and then precision treatment and a big advance in radiation therapy, the SBRT. So let's talk about radiation and therapy. Well, the choices are, conventional radiation therapy or stereotactic body radiation therapy, surgery alone. And the way I like to look at it is the way we used to think about it is surgery with radiation as an adjuvant, but with the advent of SBRT, it's now radiation with surgery as an adjuvant is a choice. You can do surgery with radiation as the adjuvant, or radiation and then needing surgery as the adjuvant to allow the SBRT, and this is the role of separation surgery. So SBRT has really been a paradigm shift in the treatment for spinal metastases. And we have Arjun Sahgal, who's going to talk about this a little bit later. I'm just going to give this little bit of focus, and we'll leave this talk, the rest of it, to him in a few minutes. But the last paradigm shift that occurred in spinal treatment was described in Lancet 2005, and this is the work of Patchell. This really was a paradigm shift because this demonstrated the benefits of direct decompressive surgical resection in spinal cord compression caused by solid metastases. And this changed the way radiation oncologists primarily, but also surgeons manage spinal metastases. It showed that for solid tumors, surgery with radiation as an adjuvant was superior to radiation alone. So with surgery and radiation, there was improvement in ambulatory time compared to radiation alone, improvement in length of time remaining continent in surgery plus radiation compared to radiation alone, length of time, the ASIA score stayed high, and the overall survival was also somewhat improved with surgery and radiation compared to radiation alone. So building on the work of Patchell, which is actually not reflected in this initial cohort in 1991 to 1998, but this really led the way for all these new changes that have been built on that. Because we thought of surgery, the combination of surgery and radiation in a different way. So there's new classifications, algorithms, decision trees, and technical advances. This is the NOMS framework, the CINS, Bilski, the use of SBRT, minimally invasive surgery, and imaging, which has improved things like embolization with interventional radiology, and also intraoperative imaging such as ultrasound. So this can account for why we're seeing these big changes in the median survival in breast and also in lung, and the change in distribution that we actually apply surgery to. So the NOMS framework, I just want to show this because when we have the cases, I want whoever's taken the case is going to follow the NOMS framework, which helps you decide on what treatment to apply and what combination of treatment. It's very sometimes it's very iterative, and the case I chose is that. The Bilski classification is used to direct a separation surgery, knowing that you have to have separation from the spinal cord, from the tumor, and you have to achieve a Bilski 0, 1A, or 1B. But once you have perhaps a 2 or a 3, you need to do the separation surgery in order to allow SBRT, because you need to have room between the tumor and the spinal cord. So again, that'll be discussed a little bit later. Surgical treatment, the choices: open, minimally invasive with the use of navigation, venous fixation, use of vertebroplasty, kyphoplasty, and also the use of ultrasound intraoperatively to assist with the decompression and ensure that you have good separation. Here's an example.
Come on, let's go, honey.
Here's an example of a tumor, and in order to achieve, in order to perform SBRT, we need to do separation surgery, and here you can clearly see, you know, a Bill 2 or possibly 3, and in order to get appropriate separation, the use of an ultrasound, which Jeremie Larouche is going to talk about today, and this is one of the areas that he's very using quite a bit and studying this. So here's an example of the use of intraoperative ultrasound for determining good separation. Another technique, the minimally invasive approach with vertebroplasty, kyphoplasty with combination therapies to allow more of a personalized treatment. And this is something Albert is doing a lot with radiofrequency ablation, photodynamic therapy in combination with the vertebroplasty. And as I mentioned earlier, Leo DaCosta, who'll be talking about the importance of embolization in order to deal with some of the more bloody tumors, such as renal cell. He'll be talking in his role and the expertise he has. So, this is a new paradigm. It says new paradigm ahead, but we're in fact in the middle of a paradigm shift. And the cases that we're going to use, we're going to demonstrate the multidisciplinary nature of the treatment for metastatic spine disease, highlight the expertise we have at Sunnybrook, show a spectrum of presentations, and remember, there's more than one way to skin a cat. So from that, I'm going to hand over the podium to Jeremie, who's going to present the first case with a multidisciplinary approach with Arjun to discuss the SBRT aspect, and Leo, who will discuss the embolization. And then I'll follow with the case, and Carolyn Lai is going to have a third case of an emergency management.
Julie, you wanted to administer a poll somewhere?
Yeah, well, I have a poll for my case, which will be, you know, embedded in the middle of the case I have. I don't know if Jeremie and Arjun have a poll, but
no, I don't have a poll. I just want to encourage discussion. So
okay.
I'm good with that.
I'll let you know when I just want to. Okay, so I've stopped sharing.
Okay, so let me see if I can take over. And we'll go. Okay, does everybody see this and I'm on full screen?
Yes.
Perfect. So what I wanted to do is talk about a case, and I really want to open it up. And I know it's kind of sometimes less interactive when we're on Zoom, but I really want people to feel comfortable to kind of talk and interact. One of the things that we started doing maybe about 6 months ago is the second Wednesday of every month, we've kind of opened up a kind of discussion forum for all of the Ontario universities and hospitals to kind of share some of their cases in terms of metastatic management and talk about different strategies. And, you know, there are a lot of different tricks and tips out there, but I think there's also a few pitfalls out there in terms of people that can sometimes make some decisions that may not have the best outcome for the patient. So I think it's important to have a multidisciplinary team for a lot of these. You know, I routinely bounce these cases off my colleagues. I have a good link with a lot of the radiation oncologists because they have a wealth of expertise and have seen a lot of things that you want to avoid. And it's also important to be able to talk to your neurosurgery colleagues or your ortho colleagues, depending on your skill set, back and forth. So I want this to be a discussion case. This is someone who's 62. She's had a previous delayed diagnosis of thyroid disease, unfortunately, because of the pandemic. She's supposed to have her thyroidectomy sometime last March, right at the beginning of the pandemic. It got delayed till about July, and she started having some back pain in October of that year. She's neurologically intact. She has an ECOG 1, so she has a little bit of pain that limits some activities, but overall she functions very well in terms of still independent, was working up to a few weeks ago, and has this radiograph. So I want to pick on someone who's not from Sunnybrook, so I'm just going to read down the line. Dowie, you around? How about Dr. Pelletier, still fresh in isolation?
Hi. I'm at Sunnybrook, remember?
Yeah. Sorry, is Dowie there? Sorry, I heard Dowie. I think I just heard five in.
Yeah, hi, hello.
Hi. Can you walk me through, what do you see on this X-ray?
So 5, 4, 3, 2, 1. So we see an L1 compression at most likely maybe secondary to the metastasis, also associated with the scoliotic deformity, secondary to also the compression fracture or the pathological fracture. We also see the wink owl sign in one of the pedicles, which is 5, 4, 3, 2, 1 at 1 also.
Perfect. Right here.
Yeah. Yes.
Good. And then if you look at if you just quickly look at the quality of the bone or the shape of the bone, what stands out perhaps on this view that makes you go, oh, that's interesting?
You can see that there is like an expansion or like, I don't know if I can point, but at the posterior cortex.
Yeah, good
like,
for you.
Yeah.
So see, instead of a square wall, it's kind of a rounded
Yeah, expanding. Yeah.
Yeah, so those are great pickups, because even there, if you're just walking down the computer screen or you're looking at a CT scan, if you see kind of a rounded posterior wall, that should be a hint in your mind saying, huh, it's probably not just an osteoporotic fracture, there's maybe more. Now this one's more obvious with the wink and owl sign, and then there's also involvement of a little bit of L2. You can see more lucency within L2 itself.
Exactly.
So there's a lot of good findings, even on a plain X-ray, to be had just by looking at this before we even delve to the next level. So she got an MRI first, and I'll show you a few cuts, but the challenge is that she really has two different problems. So remember their little winking owl sign that we saw before? This is the disease that was wiping out the pedicle and now is growing to the posterior aspect of the spine. The body of L2 that had a little bit of disease was there, but she also has this farther up. So this is T12, 11, 10, T9. She's got this posterior expansile mass. And I'll show you some of the axial views. So T9, she's really a Bilski 2. There's still a little sliver of CSF visible. And you can kind of tell that it's the pedicle is the origin on the right-hand side. And it's kind of been quite expansile. And by the time we go down to where the conus is, it's probably a Bilski 1C, where there's abutment along the neural elements, but there's still a ring of CSF, and I don't think the cord is deformed. Switching over some CT scans to give you a better idea of what we're looking at. This is level of T9, where you can see there's significant involvement of the dorsal elements here. And then there's almost a complete loss of the anterior vertebral body. The one pedicle is still intact. The other one is almost completely gone. And there's been some tumor invasion both proximally and distally. So in summary, there's a lot of different radiological findings. This is a pretty diffuse case. So in terms of management, what I tell people is, Dr. Finkelstein had a really good point where the advances of stereotactic body radiation therapy are really impressive in the last 10 years of what they can offer. So really now, when you think of your surgery, it's not just a surgery in isolation. It's really a surgery as part of a team where you're going to be working with other individuals and to try to achieve a good outcome. Before we decide what the next steps are, you kind of have to think in yourself, there's really three ways to manage this. You can either do something non-operative, where you're trying to do things like radiation only, or pain management or palliative care. There's some procedures you can do that are minimally invasive. So I would probably consider things like a vertebroplasty, a kyphoplasty, and sometimes even like percutaneous screws can be really minimally invasive. Or they can be something that's more involved in terms of a surgical decompression and stabilization. So Dowie, if I give you all three of those branches, what's your thought process? What are you thinking right now about this case?
So to be honest with you, I'm thinking about two different things, like the one at T9 and as a separate entity, and one involving the L1 and L2 as another entity. So I'm thinking, how can I help the patient? So you know that we can manage that disease itself, but I believe that these severe deformities at the L1, L2 may result in a severe back pain that can affect the patient. So I might, like, for example, for the one at T9, I might think of PERC screws one level above and one level below, and just more separation of the tumor from the spinal cord at that level, and leave the rest for radiation therapy. However, when I consider the one at L1, L2, I think that the radiation therapy will get the tumor under control. I believe so. However, I think that the alignment and the deformity may still render the patient with severe back pain. So I'm thinking both options, whether just radiation or to make it more of deformity correction surgery with corpectomy at these two levels. So these are my two thoughts about the level of L1, L2.
Which is good, because I think you're right in the sense that there's more than one way to look at this, is more than one way to look after this patient. So I think if you look at, sorry, go ahead.
More than one way to skin a cat.
More than one way to skin a cat. I agree.
Exactly.
So if you look at what we're trying to figure out, the big joke is, which I really like, is when in doubt, examine the patient. So if you go and look at this lady, she really has not tumor pain. It's not like she has a pain at night when she's sleeping or pain when she's lying down. She really has a significant amount of mechanical pain. She says, listen, if I lie down, I'm good. If I'm on my lazy boy, I'm good. The moment I stand or flex forward, I get this terrible back pain that radiates around to my chest. And I have no weakness in my legs right now. There's no neurological concern at this point. So then you really have to look at what you're trying to achieve in terms of your patient care. So obviously, we don't want to give her any further complications than she already has. But if I say, listen, can I do something like a vertebroplasty, kyphoplasty to make a difference in her life? I think in my mind, the answer is no. And I don't think that it's safe to be able to do any vertebroplasty or kyphoplasty level. I think the disease is too extensive. There'd be a really high risk of fracture or cement within the canal. The second thing I want to think about is, what can I do that's going to minimize a complication that might happen a few weeks or a few months down the road? So the challenge with her is that her tumor is growing rapidly. She still has some treatment options. She's fairly naive in terms of her treatment so far. She hasn't had much radiation. She hasn't burned any of the bridges yet. But we have to talk about what environment we can create as surgeons that can help your colleagues achieve their best outcomes, and what I can do as a surgeon that might hinder them. For example, something like a crosslink. So I want to pause here for a second, and I want to flip it to Dr. Sahgal, because I want him to kind of talk to you guys about what they look for in terms of surgery decision-making, and often the conversation that we have together between a surgeon and a rad onc as to what needs to be achieved to get the patient's goals under optimized. So Arjun, you there?
Yeah, I'm here. Can you hear me?
I'm gonna stop sharing for a second. Okay.
No, you can, why don't you go back to it and just go to the MRI?
Okay, sounds good. Let me just do that. Share screen. Okay.
Yeah, that's good. Okay, so let's talk about this lesion first, okay? So here you have baseline compression fracture. You do have multi-level involvement. There is malalignment. There's involvement of the posterior element. So this person has all the makings of either frank instability or very high potentially unstable, depending on how you calculate the SINs, okay? So right away, you know that this is going to go badly in this location from the instability point of view. The second point of view is the disease or epidural disease kind of point of view. And this is a transition zone. So there is a bit of cord there, but it's mainly cauda equina at this level, right? So everything is kind of filtering out. But the impingement that we're seeing is, there are two issues once you get into the cauda equina. Number one is, can you make the radicular pain better with radiation alone? And I would say no. So if you can decompress the nerve root, you're going to help the patient in terms of the radicular component of the pain in the longer term. And then there's the concept of maximizing the ability of the radiation to achieve as good of a dose distribution at the edge between the tumor and the dural sac. So if it's deformed like this, then we're not going to do as well, because it's really hard to hook the radiation around very nicely. It's certainly easier when there's a nice round dural sac that we have to plan on. Here, because it's indenting in, it makes it tougher. So we're going to lose coverage. So the difference between separation surgery in the spinal cord and separation surgery in the lumbar spine is that we're not talking about removing tumor to make more room for the spinal cord. Here, what we're talking about is actually creating a more favorable anatomy for the radiation dosimetry, okay? And that's an important concept that we really haven't flushed out right now in the literature. And it's one that I'm evolving in terms of making people understand this, because they're two fundamentally different issues depending on where you are. Now, the concept of tumor bulk. So that was a good point that was raised. The radiation can help. There are two things you have to remember. What are radio-resistant histologies? Well, certainly melanoma, renal cell, sarcoma, GI tumors, and I include thyroid tumors. Now, Sloan Kettering also does, some others don't, but I'll tell you, in our experience, controlling bone-based metastases from thyroid cancer is very difficult. The reason why it's been traditionally thought of as radiosensitive is really in the primary tumor, not in the metastases. So I consider these to be radio-resistant. So what am I looking for in this area of the spine for this patient? Knowing that if I treat with stereotactic radiation, the chance for further fracturing, I mean, one's probably maximally compressed anyway, but the vertebra above and below is going to be taken in that volume, and the chance of further fracture is around 35%. Okay, so I want stability, and in this case, it's multi-level, so likely instrumentation. We want decompression to reconstruct the dural sac. We want tumor debulking is really neither here nor there for us, because with the high doses of radiation, we can control it. And if there is lytic areas that you wanted to do some cement at the same time, great, okay? Now, Jeremy brought up a good point. What are things that we do not like in radiation when we see the postoperative picture? Well, we hate crosslinks. If you want to really use crosslinks, and it's debatable in the non-trauma patient, then go really at the top and the bottom. Don't do it at the levels of where the cancer is. And I personally don't agree with screws in the diseased vertebra. Okay. Yeah. And because you'll never be able to see what you're doing in the follow-up. It obscures the imaging. And it can cause tumor extravasation. Yeah, maybe Jeremy did do that. Naughty. All right.
I keep telling him that.
Yeah. But it's
Arjun, can I ask? I'm going to show you the other level. So, what if you had this in isolation?
Yeah, so then we're going to get to this level
with nothing else.
Right. So in this level now. So then we'll get to this level. So here. Now here we're in cord, right? So here we want that separation, okay? So we want you to give us space to optimize the dose between the spinal cord and the disease. The dural sac will get reconstructed, and that's okay, because here we plan actually on the spinal cord constraint. In the cauda equina, we plan on the thecal sac. So here we want separation. Now you don't have to do crazy and debulk the tumor, but you're right there anyway, you might as well do it. Now, do you need stabilization here? If you did, it would be probably nice to have it perked, but otherwise, that's not as much of an issue as the other one, because there's no baseline fracture.
Perfect. Does anybody have any questions right now for Arjun? So I'm going to invite Arjun to come back and talk at the end, but in terms of talking about SBRT, what they look for, or considerations for surgical planning, does anything jump out at you guys right now? Perfect. Silence. Kunal, if you don't use screws at the index level to even hold down potential cement, what strategies would be used to keep cement from migrating? K-wires are annoying. That's a good question. So Kunal, I'm going to defer the question for just a few minutes until we get to the other aspect of this talk, but I won't forget it. I'll keep it there. So what I tell people is that I think for all the reasons that Arjun says, what's great is, Arjun talks like a surgeon, and he looks at anatomy and instability like a surgeon, but you have to remember, he's a radiation oncologist. But it's fantastic to hear people having the same language and same consideration, where 15 years from now, or in the past, it would have been totally different things. So the one things that I talk about as treatment decision is, whenever you're a good spine surgeon, you need a good plumber. And my favorite plumber is Dr. DaCosta. And I've invited him to give him a little bit of a talk today about some of the considerations of what we need to look out for, and talk to you about what he does for this case. Leo is still there? I think you're muted, my friend.
Yeah, I just lost you here. Sorry. When you said I'm your favorite plumber, I got so like emotional. So, as you know, I'm a neurosurgeon. Arjun, you'd qualify to different levels of surgery. I think you make a cut, but that's okay. We'll take you. I mean, I don't want to bother you with the details going over the case for the embolization because that would take 2 seconds. So what I spoke to Jeremie and what we decided to do is that I would show you a small presentation regarding spine embolization. Some of you may have seen it already because it was shown here at rounds, but I'm just going to go over it very quickly so we can understand the issues. And it's just a way for me to organize my thoughts a little bit. So I'm going to share my screen here, and hopefully I'll be able to present. Just let me know if you can see the screen.
Yeah, we're all good.
Okay, so I mean, you guys all know this, and we've discussed this, right? So we don't have to go over too much detail on this. And the supposed benefits is that we decrease perioperative blood loss, which in turn would facilitate tumor resection, and it could, in theory, improve surgical outcomes, right? So you'll be able to see better, you'll be able to work at a better pace, and you'll be able to resect more tumor and do a proper instrumentation without having to rush. It's not the only factor that will decrease blood loss. So if you have a very large tumor, it doesn't matter how much you embolize, it probably will bleed. If you do a very complicated operation, the likelihood that you will bleed. The same thing applies for anything, right? So if you do a very complex corpectomy and things very, very big, you lose more blood. And of course, how much we can embolize. And this is dictated by, of course, who's doing it, how you're doing it, what you want to achieve, the level, and what's the blood supply. And this is what I want to go over with you really, really briefly, so you understand. So Arjun already spoke about the tumors that bleed and the tumors that are sometimes target for us. You can think about embolizing tumors based on histologies, right? So if you have a renal cell carcinoma, that's the one that we see the most commonly, esophageal carcinoma, hepatic carcinoma, thyroid. You can also have some MRI findings that will suggest that this tumor is very vascularized, such as too much enhancement on the contrast scans, large flow voids, within the tumor, and of course, evidence of intratumoral hemorrhage. None of this is 100%. Of course, you can think the tumor is very vascularized, and you go in there and there's nothing, and an MRI that looks completely benign could still bleed. So most of the work we do relies heavily on spine embryology, which I know it's a topic that we all love dearly. So I'll go very quickly. And the vascular anatomy is important because there are many. At the beginning, we all have blood vessels to all the levels. Eventually, this will form anastomosis between these different levels. And further down the road, these anastomosis will lead to some of these levels disappearing and becoming atrophic. And this is not symmetrical, and it's not the same for between patients. So you need to actually look for the vessels and pay attention to the different ways that they are formed on that particular patient. The blood supply for these tumors, I also won't bother you with this, but if it's cervical or upper thoracic, you need to think about the vertebral artery. And of course, that carries a risk of brain damage if you do something that it's too aggressive. And the other arteries that would supply head and neck tissue. And if it's lower thoracic, lumbar, and sacral, will be the intersegmental arteries, and also the lumbar arteries and the sacral arteries. We use many things to embolize these tumors. The most common thing we use are the microspheres. They're like little PVA pellets that will eventually disappear. So if I do an embolization, it's perfect and everything is fine, and you don't operate on the patient 2, 3, 4 days after, in all likelihood, those particles be absorbed and the tumor will recruit more blood supply and you'll be on the same situation. We use sometimes Gelfund for bigger vessels, but this will provide a proximal occlusion. There's no Gelfund going into the tumor. We use coils either to close proximal vessels or to direct flow towards the tumor and away from structures that you want to preserve, be that the skin, the muscle, and everything else. And there's some recent series using Onyx, which is a new embolic material that is liquid, and we can inject into the tumor. So to help closing that. Onyx is probably a more permanent solution. So because we use lots of particles, so the important things to know here for you as a surgeon is that they recanalize, right? If you look at the lower, the last bullet here, you'd see that they will recanalize completely in 4 weeks or so, and you want to operate within a day or two. And here at Sunnybrook, very often what we do is that we book everything for the same day, so we can do on one single anesthetic. Jeremie knows that I almost never make a mistake, and this is fine. And if something goes wrong, it's probably with his surgery, not with my embolization. So we already established that. The only reason to do it in different dates is because one, it could be a very long procedure, and two, jokes aside, you can have a massive infarct from the spinal cord and you don't really know what's going on, and you're operating on a patient that is essentially paraplegic. So in some places you do the embolization, wake up, examine the patient, give them a little break, and then a few days later you would operate on that. Of course, the availability of resources and logistics has to be also taken into account. So there are a few points that for us as plumbers are important. One is identify if that vessel is supplying the spinal cord or not. So we need to really identify that and make sure that we're not missing anything. We do these things under general anesthetic because that minimizes patient discomfort and also helps us to decrease the amount of movement. We do it in a very magnified view. So you'd see, I'll show you a case very soon, and you'd see that even with the patient breathing and even the bowel movement, it causes a lot of changes on the imaging. We do use some catheter techniques, which I'm going to show you, to help us to inject beyond the levels where we think that there's some concerning vessels, concerning anastomosis. And we are really, really careful with reflux of the embolic material into the parent vessel, especially if we're working in the vertebral artery or close to the spinal artery. And we don't really use neurophysiological monitoring for that. So the main thing here, this is an illustration from the Journal of Neurosurgery Spine, and you can see that there's a guide catheter up here in the aorta, and there's a small microcatheter going into the vessel that it's feeding this tumor. And you can see that one of these branches is going through the spinal cord, and you can see the hairpin turn, that it's typical of the arteries that supply the anterior spinal cord, anterior spinal artery. And using these techniques, you could isolate this and embolize this part of the tumor, and then come back and embolize this part of the tumor, and then leave this vessel behind, at least interior. So this is the goal. I mean, if it's easy to do or not, that's hard. So I'm just going to show you a few pictures. I'm not going to go over the details of this one because we're discussing the case with Jeremie. So you can see this MRI here, where you can see the flow voids, right? You see the little dots, you see the tumor enhancing. So, and this patient has a history of renal cell carcinoma. So we do the angio and we identify the level of the tumor. We can see some of the vessels. When you see those vessels going along for a long way, you start to become a little bit concerned. And sure enough, just before the level of the tumor in L2, you can see the artery going in and then turning into the anterior spinal artery. So this is a vessel you cannot embolize because you would cause paralysis. But we can certainly get some more selective injections much closer to the tumor. So now the aorta is here where my catheter is, and I'm going in there. And you can see how much blush there is into the tumor. You can see the contour of the vertebral body here, and you don't see any of that artery there. And this is a preoperative picture on the right side, and this is a postoperative picture on the right side. So this should help to reduce blood loss, right? So this is the final injection on that one. Once we use the Gelfund to obliterate completely this vessel and this anastomosis, and this is the goal. So some little tips that helps you to decide when to call us or not. So an MRI can predict if the tumor is vascular or not, but it's less for to rule it out. So if a tumor does not look very vascular, it could still bleed. So you may want to plan for blood loss if it's a big operation. There's some tumors that are vascular on the MRI, but they don't bleed. I mean, we don't operate on them much, especially multiple myeloma, but they could be treated without embolization. We do these procedures using an arterial groin access. So there's a puncture to the artery, the femoral artery in the groin, which we're usually able to close at the end of the procedure. So this is not a big deal if you're going to operate on the same day, but you certainly want to have one of us to go there and check. I always go up or send a fellow up to check after the positioning to make sure the groin is okay and everything is fine, because you don't want the bleeding to happen without this. And operate relatively early after the embolization, same day or a few days after. The reports show a very different impact of a preoperative embolization on the blood loss. I guess it has to do with those factors that I mentioned before. I mean, what kind of tumor you're doing and how well you can do. Of course, how much surgery you're doing for that particular case. So if you do a corpectomy, you certainly will lose more blood than if you do just a laminectomy. And for cervical tumors, we're a little bit more concerned about doing embolization because there are many anastomoses that are usually not seen until you sacrifice one of the vessels that are feeding the tumor, and it's causing significant shift in the flow towards the tumor. Once you close that flow, you can see that vessel opening up, and that could be a vessel that will go to the spinal cord, to the brain. So I'm not going to bother you with this anatomy. You just can focus on the spine anatomy. And there's, of course, some complications. So if you're adding a procedure to your treatment, you're adding complication risk. If we do a spinal angiography, the risk of a complication is probably under 2%. That includes groin complications and everything else. If you do embolization, the reported risk of complications go up to 8.5%. And that includes complications with the access, complications with the aorta. You can have dissection. You can certainly have muscle necrosis and wound complications. We had a pretty bad one here at Sunnybrook. It didn't bleed a drop, but everything was basically dead because of the very aggressive embolization. So it's a balance. And of course, the higher you go into the spine, the higher is the risk. So in summary, there's not much evidence to say, okay, you must do embolization. Some people would still operate on these tumors without embolizing, but I guess there's no trial saying that you need a parachute anyway. But we usually do it for these tumors that are more vascular than we like. So in summary, you can consider that for this list of tumors that I mentioned. And you'd want us to make sure that we don't embolize vessels that are with the spinal cord, and just see it as an extra tool, because we're not able to prevent an absolute complete zero blood loss, even if the best embolization possible. So if you have any questions, let me know, and I'm gonna stop sharing this. I think Jeremie wanted to show a case or something. Is that
maybe I'll just ask one question too. Is anybody aware of a randomized trial of embolization versus not? Any of the fellows? So there was one. It was done several years ago, and I think it was a European one. I'll have to dig out the paper, but it really showed no difference. However, in those vascular tumors like renal cell, they did show a difference in that subset. It was a small subset, so it was a small study, but there is some literature to support embolization in vascular tumors.
So what I found when I was doing these things is that there's like about a 50% reduction in blood loss depending on what kind of tumor you do. So it still could be quite a lot, right? I mean, but instead of bleeding like 4 liters, they'll bleed 2, depending on what you need to do. But of course, I don't think there's anything that it's for a particular tumor. So this will be where the benefit is, right?
And I think that, as was said, I think it's really important to embolize the right tumor. I don't think there's a benefit of embolizing everything, but in the right tumor, specifically thyroid and renal cell, it makes a huge difference. So just the last point I want to talk about is, I think that's what's really helpful is after Leo embolizes, I often go up and get a debrief. He'll show me the pictures and I'll say, listen, I got this branch very well. I couldn't get as much here. So it actually helps me plan my resection, because when I'm debulking the tumor, I'd much rather start in an area that's been very well embolized and minimize the blood loss and establish the planes between the dura or the PLL, and leave the part that I'm going to be more concerned as being more vascular for the very end. And they're normally, because of the selective embolization, it's normally pretty good in terms of mapping out and their ability to predict where the blood loss is going to happen from.
Okay.
So quickly, just I know that there's a big case. So we decided to do this as an open case to give her the best chance of a good outcome in terms of addressing her pain. What I want to point out is, because of the significant collapse, I always tell people that when I think about anterior column reconstruction, I think about if they're already 90% of the way collapsed, it's way easier to shorten someone than it is to lengthen someone. So I know that when we talk about deformity, we often talk about doing corpectomies in expandable cages or T-lifts and trying to bring people up in terms of height. In tumor, when the bone is soft and the bone is already collapsed, it's easier to regain your alignment often by shortening them. So what I did is I just took out the two pedicles back there of L1, and I didn't go out and try to clean everything up as best I could, because I know this is all going to get radiated and kind of be scarred in anyways eventually. I'm a big fan of augmentable screws for osteoporotic bone in terms of shortening the construct. So these are cement augmentations. And then I was trying to behave. I only put one screw in the level of the tumor above that was on the non-affected side. But I think that one of the things that I really try to use is the intraoperative ultrasound in order to help determine appropriate separation. So it's good to get feedback from a radiation oncologist. And it's good to know that if you do an MIS surgery and you didn't get everything you wanted to, you want them to let you know on their radiation planning CTs and MRI where this, the deficiencies were. So this is the level of L1 where, because we did a corpectomy, we'll open up the dura quite open. There is a little bit of bleeding and a little bit of some residual, but that's not tumor. And then the level of T9 where there was cord impingement, as was said, because the tumor is so dorsal, it's really easy to really get that whole tumor debulked and to be able to provide a significant expansion for the cord, which allows better postoperative radiation. So this patient's about 2 months out. She's doing quite well. The last thing I want to leave you guys with in terms of paradigm shifts is a paper that was just recently published, and Arjun is on it. One of our own residents is on it. And I think it's an important one to really make people think about one of the rules that we used to say. And we used to look at people say, if we think we have less than 3 months to live, you shouldn't have surgery. And the 3 months was really just an arbitrary number that came up when people were starting to look at studies to try to figure out, outcomes of surgery for tumor. And so what Dr. Day and Dr. Versteeg and Arjun and everybody else showed is that even if you do the right surgery on the right patient, they can derive benefit even if they don't survive 3 months, both from an economical perspective and a patient report outcome. So I tell people that for me, the performance status probably trumps everything else. If they're an ECOG 0 and ECOG 1, even if the tumor looks bad like this and it's more than one level, you could have a conversation saying, listen, maybe this is someone I could help and I could do something to intervene. And if the tumor doesn't look that bad and they're multi-level and they're basically out of breath just sitting there in their chair, that ECOG status for me probably trumps a lot of the other predictive scores in terms of who gets an operation and who doesn't. Arjun, anything to add at the end of that?
No, I think that's great and a great summary. And part of the thing in where the communication lies for everybody is that when you have multi-level disease, it's often we have to give conventional radiation, because stereotactic radiation really is up to about 3 to 4 levels. Most centers will not do 3 or 4. We do it quite comfortably, but it is a situation where you have to talk first if you're thinking about planning your surgery with the SBRT as a next step, because there are limitations to the technique. Now, typically, when you're dealing with breast cancer, multi-level disease involving every level and this and that and everything, we're going to give conventional radiation. It's responsive. There's too many levels. It tends to be a marrow-based type of metastases. But in thyroid, because it's radio resistant and bulky, we're going to figure out how to do it. But if we know beforehand, we can tell you that, yes, this is a candidate for stereotactic radiation. Because in that situation, if it wasn't, you may want to do a more radical debulking of the actual tumor, and maybe even a partial vertebrectomy. Michael, I think you have a question.
Yeah, thank you. I'm really enjoying the discussion. So I think, I agree conceptually, Jeremie, with what you were saying, that I don't think we should be nihilistic about individuals who have a very poor survival. But I think the challenge is dealing with the outliers. And so, a lot of the clinical decision-making are the patients that follow kind of the typical course, since the average life expectancy is just under 8 months for someone with a spinal metastasis. But the challenge is there's a lot of outliers. So you have people that have very poor survival, and then you have people who have very long survival. And I think that's kind of one of the challenges. So, the patients with poor survival, I think it's inappropriate to leave somebody in a lot of pain if there's something that's simple that you can do. But I think the challenge there is not to do some huge procedure where, by the time the patient recovers, they'll succumb. You want to get them home. And then in the individual where you anticipate years and years and years, you don't want to do something overly minimalistic, because then they're going to get recurrences and the challenges. And I think this is kind of where the challenges are. And, there's been a lot in the literature on clinical decision, rules. And I just want to kind of do a little bit of a shout out to Anik Nader, whose PhD thesis was kind of focusing on some of the clinical decision making. But I think what's going to happen is that, and Joel alluded to this kind of with the lung cancer, right? So as we start understanding more about the molecular genetics of these different types of tumors, we're going to start, I think, being better at personalizing the approach. And I think that's going to be, a big impact. But anyway, really enjoying the discussion. So I just wanted to kind of get a little bit into the kind of the concept of personalized medicine, and a little bit of a plug-in for kind of Anik's work around kind of looking at some of the outcomes predictions. Thank you.
Okay, well, thanks very much, Jeremie, Arjun, and Leo. So that really is the one end of the spectrum of how maximal we can get. And, if you do the right thing for the right patient at the right time, you're going to get the right outcome. So you have to do the right thing. If the right thing is the big thing, then that's what it is. But I'm going to show, I chose this case because I wanted to go to the other end of the spectrum. And this is, I'm not trying to give it away, but it's really, there's many ways to deal with this. So this is a 55-year-old male with colorectal cancer.
Joel, do you want to share your screen?
Oh, sorry, is it not shared? Okay. Do you have it there now? Is that?
Yeah, it's just not full screen yet. That's all. If you just click on the power, there we go.
Okay. Okay. So I'm just gonna. We have two more cases we want to present, because again, it's the third case is again different, where it's not. These are sort of pseudo-elective. I don't mean elective that they're like elective surgery, but you can think about them. The last case is emergency case. I want Carolyn Lai, who's going to present that one. So I'll try to go through this one, and I'll just ask for the panelists' input. So 55-year-old male with known colorectal cancer, diagnosed in 2018, December 2018. It was deemed to be non-resectable, so it was treated with a diverting loop colostomy, chemotherapy, and radiation directly to the rectum. December 2020, so about 2 years after the primary diagnosis was made, he has a 2-month history of back pain and left leg pain, which is to the anterior lateral thigh and just above the knee. So, just based on, the primary, we talked about the, when you're thinking about it from the very beginning, we're going to treat this with radiation or surgery. Arjun talked about radiosensitive, radioresistant tumors. So is this a radiosensitive or more radioresistant tumor, if we're going to put that into our thought process?
Yeah, so this is probably one of the most radioresistant tumors there are. It's all colorectal is bad.
So his examination, he's neuro intact. He's got tenderness in the lumbar spine, and he's got pain in his back more than pain in the leg, but he does have this radicular component of pain into the leg. And this is his MRI. So based on this MRI, you know, I'll just go through it because I want to hear what people would do in the choices. You can see it looks like primary and L3 lesion. It doesn't look like there's involvement elsewhere, and he's got some tumor in the left lateral recess. He's got this pincer type fracture with some compression of the cauda equina. And this is his X-ray. Here's a T2 weighted image for the MRI. And this is a CT scan, the soft tissue and the bony window showing you the lytic component to it. And again, the pincer component. Life expectancy, we didn't talk about this, but you know, Jeremy brought this up. Oh, we did talk about this, but when do we make decisions? The life expectancy for this gentleman was considered to be over 6 months, and he has got a good functional status. So, you know, he's someone that we're going to want to operate on. So what are the choices here? And this is where I asked Nadia, if you can put in the Zoom, the poll. Do you have that? Can you put that in now? How do you go about doing that? Okay. So we'll give everyone a chance to make their decision. Do you want me to go back to show some of the pictures, or people remember it? Yeah.
Joe, just remind, does she have mechanical pain or walking okay?
Yes, it's mechanical pain that's relieved with rest, relieved with lying down.
But able to walk?
Able to walk, but does have back pain. Has some radicular pain. The pain in the leg is not as pronounced as the back pain. Okay, so has everyone had a chance to give their response?
5 more seconds.
Okay. I can just flash through the MRIs here. Okay. So what's the majority of the people here? So the majority of the people chose MIS with percutaneous fixation followed by radiation. And the next most common was open surgery with stabilization and decompression. Okay, well, let's sort of drill that down. So the decision making clearly goes, what is the, role for surgery? If he's got mechanical pain, the SINS classification helps you decide about stability. And I scored this. So if it's in the mobile spine, he's got pain with his mechanical pain, he's got a lytic component, the alignment's normal. This is a pincer type fracture. So it's really an unstable type of pattern. He's got really no posterior element involvement. So this, was a SINS of 10. So it could be considered, potentially unstable or it's unstable. I think it needs surgery, particularly since the pincer fracture. Anyone in disagreement with that, or everyone agree with that? I see. Okay. Now, what about the role of, about separation? This is the cauda equina, so it's not spinal cord. Arjun talked about the role of separation surgery in the cauda equina, maybe not as important as in the spinal cord, and also that nerve root compression really isn't as successfully treated with radiation as spinal cord, or I shouldn't say radiation isn't as successful as direct decompression. So, what would be the thought process here? Should it you know, a direct decompression, or could SBRT, since there is some clearance from the cord or from the cauda equina, oops, since there is some clearance and, you know, it's not cord, would SBRT be valuable here, or is it too radio resistant to expect a good outcome?
I think one thing that Arjun often says, which I think is interesting, is when we talk about radio-resistant tumors, we talk about conventional radiation. When it comes to SBRT, nothing is radio-resistant. They're able to get a good enough dose, or very little is resistant. The question is that do they need the room or not? And in this case, in a Bilski 1, you know, whether you could argue is a 1B, I think that the separation surgery is probably not required. They could probably be able to contour quite accurately and get there safely. But the challenge is that if there's already some fracture, there's already mechanical pain, and the risk of further fracture increases in the short term after SBRT, that's where having something that, like you suggested, minimally invasive fixation to help with mechanical pain without the need to open up the wound and expose the soft tissues to any further surgical insult, followed by something like SBRT, I think in my mind makes a lot of sense.
Okay, so this was felt to be a Bilski 1B and a SINS 10, and he's got a pincer fracture, he's got mechanical pain. So, you know, Arjun, what would your suggestion be?
So the thecal sac is not deformed. It's all anterior. It's totally fine. So here, this is not, I mean, you know, technically you can't even use the Bilski here. And there is not really a good scale that we do. We do it anyway. We call it Bilski and we say A, B, C, but it really doesn't really fit, right? So the way, that's why I look at it, is the dural sac, you know, in a good SBRT type of position? And I would say here, yes, there is some epidural disease, but it's not a big deal. It's not a situation where we therapeutically need to resect it for the patient, for the radiation. It's fine. The biggest issue here right now is the fracture.
Right.
And just to kind of put Jeremie's comment in perspective. So it's true, the SBRT has challenged the norm of radio resistance, and it certainly has in renal cell. Like that is one where we can say, look, you know, we have changed that paradigm, but still in colon and sarcoma, it's very hard to control. We're better than conventional, but we're not getting the same rates as, say, prostate or maybe breast. And we recently published a paper on this.
Okay, so if I'm hearing you correctly, then this person may not need any decompression in order to do radiation. And radiation may be successful at treating his leg pain. Would you say that would be?
It's hard to know. Yeah, I mean, if you want to decompress the nerve root, that's a different issue as compared to decompressing the dural sac.
Right.
So if there's, so if you're in there anyway and the nerve root is squished, yeah, sure, why not?
Okay. Well, I think the difference there, though, is that if we're going to do an open decompression, we're doing more, it's going to be more invasive surgery. Whereas if we can do purely a percutaneous fixation and deal with the compression with SBRT, then we can do it completely percutaneous and not do and not open up the canal at all. So,
can't you just do it MIS, the decompression of the nerve root with the tube?
Well,
at the same time?
Yes, you could do that. You could, it would be a lateral recess decompression, and that certainly is an option. But what we felt that we wanted to try was to start to do SBRT to see if he could get resolution of his leg pain, and then determine whether he was going to need an open decompression or whether just a percutaneous fixation, because we wanted to do as minimal as possible. So that's what we did. We actually went with purely an SBRT and then a percutaneous fixation with vertebroplasty. And this is his post-operative film. So that was the hope of doing the most minimally invasive approach possible. The next thing would have been to do an open decompression with tubes, or to do it this way. So, you know, how did he do from this? So he improved his left leg pain after radiation. If he did not, I guess we would have had to gone in and do an open decompression. So it felt like we saved the ability to do an open decompression. We then went and did his percutaneous fixation, and that made marked improvement for his back pain, as would be expected. 1 month after surgery, he had started to have complications from his rectal cancer, developed bleeding, and he underwent radiation to his rectum. 6 weeks later, he developed some recurrence of left leg pain. So I don't know if this is, you know, a consequence of the fact that radiation for radicular pain just isn't as satisfactory as open decompression for radicular pain. And that could be, you know, I guess that would be maybe the learning point or the experience. What do you think? Just the fact that it's radicular pain, you just can't expect as good an outcome from radiation. Would that be, you know, your
I would say, yeah, I would agree with you, and I would say it's histology dependent. You know, so if we knew if it was breast cancer, we would potentially expect a good response. But because it's colon, you know, this is where, you know, all bets are off, and it's very hard to control these. You know, and certainly this guy had other metastases as well, I think, and you know, it's always a consideration. How hard do you go surgically? But with the imaging and what we saw, I mean, I think the approach was a good one. And the radicular pain, you have to wonder at this time period, is it because there's further fracturing or is there disease progression? You know, why is that happening? Because it shouldn't.
So that's what happens. So we've developed with recurrent pain, but if you look at this MRI now is about 2 months later, and look at the disease progression at the level of L3. And now there's progression at L2 and L1. So we can't beat the biology of this. And perhaps it was the right approach to do, but unbeknownst to us was this aggressive biological nature of this. So look at this recurrence. And I'm just putting the other MRI up, which was December, and this next MRI was in February. Look at the progression of that. So I'm not going to say that doing the SBRT was wrong as opposed to a tubular decompression, but look at the biology here. So now he's got recurrence of his leg pain. He's got some increased back pain now, and he's got this new pathological fracture at L1. So at this point, what do you do now? And at this point, we just did an open decompression, biparticular decompression of the L3. He's already stabilized. So you know, this needed a much more aggressive decompression. Now, had we done a tubular decompression, he would have progressed to this progression the same way. So you can't make a lesson out of this and say this is how you have to do it, because everything's going to be different. And the point of this is that so this is now a month after second surgery. He's actually doing much better, and we'll have to monitor his L1 level, and maybe he'll need some more radiation or possibly extension of his surgery. So the point of this is it's a very iterative treatment. Like, you know, we're actually acting on and making decisions as we go along, because we can't predict the biology of this. And had it been breast less aggressive, it may have been very successful at you know, and not needing anything else. But you have to have lots of tools in your toolbox. The initial surgery was MIS, hoping that SBRT would, reduce the need for an open decompression, but we can't beat the biology of the disease. So any last comments before we go on to the third case?
How far after radiation did you have to go back in?
He had his first radiation in December, and we went in the second time the third week of February. So.
And Michael, you've got your hand up.
Yeah, so the case is really well managed. You know, it's a difficult biology. I guess one of the comments is, and you've alluded to this, Joel, but I guess, you know, the scan may have, the CT, as I recall, may have shown kind of some bony impingement, which of course won't be treated as well with the, you know, with the radiation. So, you know, maybe that was a factor. Maybe there was a bit more kind of collapse, just a bit more kind of referred pain, but then you went in afterwards, you know, and you did the decompression. So, I mean, the case is well managed. You've treated the instability, you've treated the disease, and, you know, you've palliated the patient. You've palliated the patient appropriately. In this case, your thoughts around Perc screws versus kyphoplasty for that level. Can you perhaps comment on that?
Well, kyphoplasty is certainly a possibility for this. You could do a kyphoplasty for stability. I'm not so sure, with the pincer type fracture that it would be, that valuable. And kyphoplasty is not going to take care of rotational stability. One of the best way to determine when someone's mechanically unstable, it may not look so bad, but if you have a fracture through the pedicle and you rotate and you lie in bed and you're rotating side to side, you're getting this torquing through the pedicle. And if you have fracture through the pedicle, that's basically rotational, instability, rotational pain. You're not going to fix that with kyphoplasty. He had, a fracture through the pedicle. So I don't think kyphoplasty would have solved his mechanical pain. But it is, certainly a good option if it's purely a compression type, fracture with preservation of the pedicles. But certainly.
And Arj, what's new on the horizon with colon cancer? It's such a difficult biology.
Yeah, I'll just say this in terms of the kyphoplasty. If you're going to say, okay, look, there's some fracture there, we want to do the kyphoplasty, it's got some mechanical pain, the way that I approach the timing, because that's one of the questions, should you do it before or after SBRT? And we like it after. So at least we've treated the tumor, because you will extravasate some of the tumor, and we reported this also, and you kind of want to avoid that. So that's how I kind of approach it. If the person has such bad mechanical pain that they can't get through the treatment, then do the kypho first, because it's going to happen, but it's okay. But we do know, and there are data that actually looked at circulating tumor cells post kyphoplasty that were detected in a higher amount. So it's very interesting to see that. So that is a consideration that we always have about tumor extravasation. Forget the cement extravasation. And I think that's caused us to migrate a little bit more and more complex patients, or patients with more longer term survival, like oligometastatic disease. And in this situation in colon, there are a lot of lines of therapy, of systemic therapy for colon cancer. So if they're early on in the trajectory, they can still live for many years. But if they're in the late stages, it just goes bad. Typically, when you have bone or spine metastases, it's a late stage event, just in terms of kind of the typical nature of it. But you do have to think about that in terms of the construct. So if it's a long life expectancy and someone that we want to be aggressive with, then I would favor percutaneous instrumentation. If it's more very palliative, then I think the kyphoplasty is there.
Certainly, I think for the rotational issue, and if the pedicle is involved, the kyphoplasty will work less well. But I kind of raised it because as an option, to consider in this case. And I think the case was well managed. And I mean, the reality is you're dealing with a difficult biology that's going to progress, and that's the other thing as well. As surgeons, it's it's kind of difficult sometimes, to navigate a situation where because the patients progress, and it's very important for us to also realize that, what we're doing is not curative, and the patients will develop further issues. So that also, I think, becomes an important issue in terms of the mindset. So anyway, thank you. A well-managed case.
Okay, so the next spectrum of of this pathology is the emergency management, where you have less time to think about it and you have to deal with it, in the middle of the night, or as they come in. Perhaps if some of these cases were proactively managed, or we had a crystal ball, they wouldn't come to emergencies. But it is a reality that we have to treat it emergently. So Carolyn Lai is going to present an emergency management of metastatic case.
Can you guys see my screen?
We do.
Okay, good. Thank you very much, everyone. It's a very interesting discussion that we have. I have a relatively short case. So this is actually a case of Dr. Finkelstein that both Dora and I were involved with. So essentially, 53-year-old male. He was an urgent transfer from an outside hospital, and he had intractable neck pain, difficulty swallowing in the last couple of weeks, a sore throat, and a history, if you asked him about weight loss. He had no past medical history, medications, none. He was a non-smoker, and he was a retail worker. So maybe I will ask one of the fellows, Isaac, Julia, or Ohad, if you can describe what you see on the CT scan.
Hi, it's Isaac here.
Thanks, Isaac.
I see a C1c2 dislocation, and apparently there is some tumor involvement of is that the C2 predominantly. So it's two things: the tumor and also the deformity caused by the tumor.
Can you, Carolyn, put the display so we can see the images better? The display cup at the bottom.
Better?
Yeah, okay.
Okay. Yep. So essentially, there was a destructive lytic pathologic fracture of C2 and a fracture dislocation at C1c2 and a kyphotic deformity. So fortunately, we're able to get an MRI. So you can see here that C2 is very much involved, and there's actually the kyphotic deformity is actually draping the cord, and there's severe canal narrowing. So we, got other investigations because he had no primary past medical history. So in the chest abdo-pelvis, they found a large 13 by 11 centimeter mass at the left kidney with renal vein thrombosis, hepatic mets, and left adrenal deposits. So what do you guys think in terms of management here? And he was transferred in a collar, and I believe, Nadia, you should have a poll. So going through the options: conservative treatment, so steroids, chemotherapy, radiation, non-surgical treatment, C1c2 decompression only, C1c2 fusion and decompression, occipital cervical fusion, and occipital cervical fusion and decompression.
What are the results?
Interesting. Okay, so the most popular one was occipital cervical fusion and decompression, followed by occipital cervical fusion. And there were actually 20% of people said C1c2 fusion and decompression. So we actually went ahead and did occipital cervical fusion. So these are the intraoperative films. So essentially what we did is we put them in a Mayfield with a cervical management system, and we tried to do a little bit of traction and flexion to help with to reduce. We did this under neurophysiologic monitoring because if there was any issues, we would know right away under fluoroscopic guidance, as you can see. And we did get a reasonable reduction of the fracture dislocation with traction and, sorry, not flexion, slight extension. And then that picture is showing the fluoroscopic guided C2 pedicle screw on the left. On the right, it was entirely eaten away by the tumor. We elected not to decompress because the monitoring remained stable throughout, but we did do a hemilaminectomy on the right side of C2 to get tumor biopsy.
Yeah, I don't think there was anything really that needed to be decompressed. And I think if someone is answering decompression and fusion, we did do a biopsy. We wanted to make sure we got good tumor. So you could probably call that decompression, but it's really not decompression for the role of decompression. This is just, this one here was mechanically unstable, needed to be stabilized we needed tissue. And that was a way to get tissue, but it's not really the goal of surgery here isn't to decompress, because there's no, epidural disease specifically causing cord compression here.
And if the monitoring changed, obviously we would do decompression, but it was fortunately stable throughout. So here is the scout views of the CT scan. So we actually went from down to C5 in this case. And then the CT showing that we were able to get a pretty good reduction. And then here, the other side is completely eaten away where we took the biopsy. So post-op course was unremarkable. Pathology came back as metastatic poorly differentiated carcinoma, compatible with renal cell carcinoma, clear cell subtype. And rad-onc gave him palliative radiation, med-onc systemic therapy, and then with biologics. And unfortunately, we don't have follow-up because he went to Sault Ste. Marie to get all this done. So, yep.
He was great.
So yeah, I wanted to present it.
He was great in the recovery room.
Yeah, I wanted to present a case that's a little bit different. It's like a, cervical cranial junction type tumor, but we don't see that often.
Great. Any comments on that or any other points that you want to bring up? Certainly there's other, oncological emergencies for, impending spinal cord compression. So this is a little bit different.
Yeah, that was a very interesting case. And, I agree. It's the biggest issue is the deformity. And if you're able to get it reduced, stabilization, because of the bone loss, I certainly would agree that a multi-level construct is sort of necessary.
Mm-hmm. Well, that's all. That's what we have for our cases. We're getting to 7:30. Are there any final, points, comments that people want to make?
I think it's a great set of rounds, a very interesting set of cases. Just thank you for the presentations and for sharing your insights into these complex pathologies.
Okay.
Take care. Good evening, everybody.
Thanks a lot, guys. Thanks for joining us.
Thank you.
Thanks very much. And appreciate it.
Thank you very much.
Thanks, everyone.
Bye.
Have a great evening.